A very good evening to everybody. I know the day has been very productive and also very exhaustive. My topic today for discussion, and thank you, madam, for your kind words of introduction. My topic for today is diagnostic hysteroscopy and laparoscopy, which is a very important tool in the hands of a fertility specialist. And so we all quickly going through the routine indications of clinical practice of hysteroscopy, as madam said. Abnormal uterine bleeding, infertility, recurrent pregnancy loss, suspected intrauterine pathology like polyp, fibroid, adhesions, retained products of conception, lost embedded IUCD, congenital uterine anomalies, etc. and etc. And quickly going through the routine indications for laparoscopy, where you have to think beyond the uterus, of course, a very important part in infertility, where you have to check the tubal patency, function and adhesions, suspected endometriosis, chronic pelvic pain, tubal disease, ectopic pregnancy, ovarian cyst, adnexal masses, unexplained pelvic pathology. By the time I made these two slides, I was just trying to make a presentation on diagnostic hysteroscopy and laparoscopy about the indications, contraindications, methods, ports, the pressure, intra-abdominal pressure, everything. And then suddenly when I just made these two slides, the fertility specialist in me got kindled, and I thought instead of talking about the procedure, I wanted to talk about my small experiences that I have and have faced and have struggled through while treating the patients, and not talk about the procedure per se, because we all have been discussing that and we know a lot about it. Instead, let's talk about the procedure where we miss advising it to patients and the patients are at a loss. So basically, I wanted to talk about diagnostic hysteroscopy and laparoscopy for uncovering the invisible. So many times it is required and we fail to advise this procedure to patients, and they fail in their life in achieving success. So now, the entire presentation just got twisted into another story. So now, as a fertility specialist, I want to talk about this procedure and where it can be very important. So this is a very common story that we all face in our lives. We have patients who we say, "Aapka to sab kuch normal hai, everything is normal." But she's been married since many years, but all her reports, husband's reports, wife's reports, everything comes normal, the scans and everything is normal. Beautiful HSG, lovely TVS sonography, AMH wonderful, the husband semen analysis is very good, but she has gone through multiple failed cycles of ovulation induction and timed intercourse, multiple failed cycles of IUI, and multiple failed cycles. Then she is sent to an IVF center to undergo IVF, and there again she faces failure in IVF cycles. So this is where we should understand that actually she wasn't normal, but we weren't just looking deep enough. So what's the problem actually? The problem is that imaging, of course, is very powerful. The ultrasounds, the MRIs, the HSGs, they are very powerful, but they are, or they may be, incomplete. And infertility lies in deeper details. So this was advised to me around a decade and a half ago by my seniors, that a diagnostic laparoscopy hysteroscopy, if you suggest to a patient much early in life when she's already gone through her basic treatment protocols, will definitely give you some more insight. So a simple diagnostic hysterolaparoscopy actually changed a lot in my practice. So what happens? You get a lot of clarity the moment you see inside. There is absolute clarity of what's happening inside the pelvis. The pelvis doesn't hide or tell, it doesn't lie. It absolutely exposes what you haven't been able to see on the scans. It explains, then you can correct it right at the same point, and it transforms the outcomes. So what we actually saw, the reveal was really shocking in many cases. Early endometriosis, flimsy adhesions, subendometrial inflammation, nothing dramatic, nothing obvious. On hysteroscopies, you randomly find a polyp, convoluted tubes with a little bit of slow spill and congestion. But small things that really mattered, maybe the fertilization was not happening, or maybe the inflammation was not allowing the implantation to occur. So I just wanted to share with you all a few experiences which I had in my life. Now this is, all these patients which I am going to tell you about have normal ultrasound scans. So I am just showing the HSGs, which are very evident actually. So the HSG was very normal in this patient. She was a case of secondary infertility. Her first delivery was a C-section, and she was being treated for secondary infertility. Of course, when one woman has had a child, it is always, you take it for granted that she must be fertile and sab theek ho jayega. So you continuously, you are continuously treating her in the very basic manner. Of course, nahi hua, so then you go for IUI. Then she was also subjected to IVF. And also another very unfortunate thing about this patient was that she did not have any other vague complaints which could give you a suspicion that maybe she's having something else. I put in the laparoscope and her entire uterus was hanging onto the anterior abdominal wall. Now if you go back and look at the HSG, you can see a cervical elongation there. So the uterus was not happy enough to host the good embryos that you were putting in. So a simple restoration of anatomy in this case helped her conceive. So this was a very interesting case. Another one, this patient, very young, she had normal scans, not even kissing ovaries or any signs of endometriosis. The HSG in endometriosis is always, the tubes are always patent. And if the tubes are patent, we all tend to just treat and over-treat. And they really become depressed with failed cycles. This patient also did not have a lot of symptoms related to endometriosis. That is again unfortunate. Mostly the patients who have endometriosis, they have dysmenorrhea, they do tell you something which creates a suspicion. But probably her pressure points or whatever, I mean, she was not complaining too much, mild dysmenorrhea, normal, that she could tolerate. And when we put in the endoscope, the fallopian tubes were glued together, the ovaries were fine, but then this was clearly endometriosis, where we did the adhesiolysis, correction of the anatomy, and helped her to get pregnant. This was a patient who underwent IVF cycles for bilateral tubal blockade, and the uterus was looking pretty, the endometrium was always nice, probably the embryos, as she said, in the IVF centers where she underwent IVF were good, but she did not conceive. We put in the endoscope and we found bilateral pyosalpinx. So because of that, she was facing implantation failure. So simple salpingectomy, bilateral salpingectomy we did with the consent of the husband. And whenever we see this HSG, whenever there's an HSG which shows bilateral tubal blockade, from the past bad experiences I have learned that in the OPD, I do counsel my patient there that, we don't know what is there inside. Maybe it can be really very bad, and if so, if we find something like this, hydrosalpinx or a pyosalpinx, we may need to remove your fallopian tubes. And it may be just a minor small issue, but only when we put in the laparoscope, we'll be able to understand and tell the truth what is hiding inside. This patient again, the uterus was looking nice. One of the fallopian tube was blocked, the other one was patent. She underwent IVF, and she had a failure in implantation. As a routine now, most of the IVF centers are doing hysteroscopies prior to IVF, which I think is a very good practice. It should be done. This patient, we did a hysteroscopy and we found, you can see subtle adhesions which were not seen on the HSG and which was not diagnosed. So again, it was very beneficial to her. As one of the videos that Madam showed of secondary infertility, where a woman had a lot of bones. Now this patient again, her HSG is very clear. Her ultrasound did not show much of this. Again, these are the unfortunate incidences where the imaging could not pick small minor problems that we could. Now this is a piece very thin, flimsy, like a chip of bone which was lying inside the uterus. She was a case of secondary infertility and she was not able to conceive. So a very fruitful and rewarding procedure for this patient. Again, another HSG with patent fallopian tubes. The uterus was also looking good. And on doing a diagnostic laparoscopy, we found that the right adnexa was completely adhered and glued. The tube and the ovaries were glued together and there was a lot of adhesion. One more, this patient underwent bilateral salpingectomy for pyosalpinx, I think hydrosalpinx, and after that she was subjected to IVF. But the procedure happened around 2 years earlier. I mean, she went for IVF 2 years after the hydrosalpingectomy was done. In the meantime now, to suggest hysteroscopy, she's already underwent hysteroscopy and a bilateral salpingectomy 2 years back. Sometimes it becomes very difficult for us to suggest that आपको एक hysteroscopy करानी पड़ेगी before IVF. And uske bina, when we do IVF and she goes into failure, then she gets depressed, and this is what you see, that there were flimsy adhesions inside the uterine cavity. Rest of the endometrium was very nice. And there was a small tip, if you can see, a small point, white, if you can see, there's a small fibrotic area in the right on the fundus. So all these experiences have actually completely changed my clinical practice. You know, endoscopy has completely changed my practice, and now I do not use it as a last resort, but as a tool for clarity wherever I feel that everything is fine and I have been precise, I have been really following up with this couple and nothing is working out. Something will unfold once I put in the endoscope, and believe me, more than 70% of the times we do find situations where we really get shocked. So seeing is not confirming, seeing actually is discovering. So a simple procedure, hysteroscopy, as Madam explained, it's just a 10-minute procedure, and you know, we see things which are not always visible on scans. Laparoscopy, we are not just diagnosing the disease, we are actually understanding the function. Tubes, the fallopian tubes, they cannot function just because they are patent. They have to have zero inflammation, you know, the convolutions, the adhesions. Because of so many factors, the tubal functions are really hindered. So in IVF, as an IVF specialist, so often it happens that you get really good embryos, you're seeing a good endometrium on the scan, but there's failed implantation. But the question is, are we missing something? And the answer is often yes. A significant number of unexplained cases are not unexplained at all. There are subtle details which we should look into and understand before. So, before labeling them unexplained. This was a big experience curve that I had in my life, and I had a clinical shift from protocol-driven to patient-specific. I stopped asking what does the protocol say, but instead I start wondering what is actually the patient hiding inside herself. So when we should intervene? When you know you have been treating regularly and she's not conceiving. Then, in recurrent IVF failure, long-standing unexplained infertility, and suspicious but inconclusive imaging. The future, of course, will be getting us better integration, precision, insight, and imaging will improve. AI will be of great assist, of course, but nothing will replace direct visualization. So what we don't see is often what prevents conception, and endoscopy reveals the truth. So sometimes the answer is not more treatment, it's just better understanding. Thank you so much.